Good morning, ladies and gentlemen. Welcome back to the presentation. And I'm presenting optimizing virologic outcomes for pregnant women in Uganda. And I'll be focusing on Southwestern region. As of the background, we all know that our target is 0 infections in the children. And for us to have also the HIV-free generation that we are all striving to achieve, we need to ensure that no child is born with HIV. However, poor retention, poor adherence, non-disclosure, and non-viral suppression have been identified as major gaps in the EMTCT cascade, which is the key program that is looking at elimination of mother-child transmission of HIV. And we have also seen evidence that HIV viral load is the principal determinant of mother-child transmission risk. We also have an estimated 44% of adults living with HIV in Uganda that are not virally suppressed. That is by 2016. We still have evidence showing that peer support and counseling have been crucial in addressing these gaps, and they have also been crucial in contributing to the attainment of the third 90 of the UNAIDS target, which is the viral suppression that we're interested in. And in Uganda, we are still seeing that we have about 3,500 new infections in children occurring, which is a clear indicator that the problem of HIV transmission among children is still present. So for this project, we have a hypothesis, like I mentioned before, that counseling and peer support has been crucial in addressing the third 90 of the UNAIDS target. We hypothesize that if we come up with an enhanced viral and peer mother support intervention, that would increase adherence to ART, and that would also result in increased viral suppression, hence the reduced risk of mother-child transmission. And so for this project, we have some questions that we are interested in answering. And one of them is, what is the prevalence of viral suppression among HIV-infected women? And also identifying what are the predictors of viral suppression and non-viral suppression among pregnant women. And the second question is, what would be the effect of this enhanced viral counseling and peer mother support on viral suppression, as well as retention and care? And then the third question is a qualitative question, looking at the barriers and facilitators to implementing the enhanced viral counseling model and peer mother support intervention, but also trying to understand what are the barriers to suppression for the mothers who will not be suppressed at the end of the study period. What are the study objectives, or what are the study aims? The first aim, which is the main focus for this project, for this course, is to determine the prevalence and identify predictors of viral suppression among HIV-infected pregnant women. The second aim is to evaluate the effectiveness of the enhanced viral counseling and peer mother support intervention on viral suppression among HIV-infected pregnant women. The third aim is to evaluate the effect of this intervention on retention in care at 18 months postpartum or post-delivery. And the fourth aim is basically to assess the facilitators and barriers to implementing this intervention of viral counseling and peer mother support. And also have the secondary aims, which will be evaluating the effect of this intervention on the incidence of mother-child transmission, and that is at 18 months. And the second secondary aim is to look at the personnel time required to implement this intervention compared to the standard counseling. Just talk about the intervention and what it entails. Like I mentioned, there are two major components of the intervention. One is the enhanced viral counseling, and the second one is the peer mother support. And the contents of this intervention is mainly to make sure that whoever is providing the counseling, and in this case it will be the counselors, mainly the nurses and counselors, that they are explaining what a viral load means and the importance of viral suppression as well as monitoring, with a mind that this knowledge would enable both the provider to provide the targeted information, but also we also think that at the end of the day there will be demand creation, so that if you know the importance of viral load suppression to you as an individual, then you're also able to demand for this monitoring at the end of the day. It also includes assessment of adherence and counseling based on the results of that visit, and also the schedule for the next viral load. So if a client comes to the clinic today and you're discussing their viral load results, they should also be able to understand when their next schedule will be. And then also the counseling messages are based on the role of viral load and the mother-child transmission risk. So if I'm a pregnant woman and I've come to the clinic, knowing what the role of the viral load is and as far as MTCT risk is concerned is going to be a crucial component of the enhanced viral load messages that we'll be providing. And then the peer mother support, we know that peer mothers have been used previously and they have been successful, but we are adding a component of training so that in addition to the nutrition education they give, in addition to many other things they talk about, they're actually going to focus on viral load counseling with knowledge that will have come from the training. And they also help in the follow-up of the mothers in order to continue with the adherence and disclosure support counseling. And this intervention is going to be guided by the PRECEDE framework, which we have looked at previously, and we'll be looking at the predisposing factors, the enabling factors, and the reinforcing factors. And for this project, we are focusing on a number of barriers, but majorly the knowledge gap, both at the mothers and providers level. We are also looking at the delayed adoption of the guidelines, given that we have moved on to viral load monitoring as a country and also the WHO guidelines. And then we are also looking at disclosure support because we have evidence that, when we do not have disclosure, then that has been a serious predictor to non-viral suppression. So the study design, this study is going to be in two phases. We have phase 1 and phase 2, and it's going to be a before and after cluster randomized trial. And in phase 1, we're going to have a retrospective study on the prevalence and also identifying the predictors to viral suppression in other clinics, and this is specifically for AIM-1, and we shall be using the search study that Darson had talked about previously. We have data that has been collected on pregnant women and also on their viral loads and some of the variables that we're interested in. And in the second phase of the study, we're going to randomize 10 clinics into intervention and control, and the control clinics will basically remain implementing the standard of care, which is standard counseling and whatever is going on currently, while the intervention clinics will be implementing the enhanced viral counseling and peer support intervention that I've already described. And then this will be implemented, and we will be measuring viral suppression as the primary outcome at 6 months, at 12 and 18 months, and then we shall also look at retention in care as well as the incidence of MTCT. So think about the progress that has been made so far. We have received all the necessary requirements to proceed with data analysis for AIM-1, which is the main outcome for the implementation science training that I just completed. And I also have a complete data set, and data analysis is already in progress. And I have also submitted to the IRB and HEDREC the next 3 aims to be developed into a full PhD proposal, and I'm currently awaiting their approval and comments. In terms of the next steps, we are going to complete the data analysis for AIM-1, and we hope that this publication should be submitted by June. This manuscript, sorry. And I hope to finalize the development of aims 2, 3, and 4 of the proposal and work towards the implementation early 2018, and make sure that we have acquired all the regulatory approvals by November 2018 this year. So thank you so much.
Thank you very much, Jane, and you are right on time. I have some big questions, and then we'll take some others. One is for your third aim. I was wondering what your target population is. Is it the health care providers or the mothers? And then the second comment is certainly when we do these studies, we want them to be generalizable in the outer world, and I think that's where implementation science thinks so much about external validity as opposed to internal validity. You have a control and intervention, and I guess the intervention really is because of the enhanced support for biosuppression that we're going to do. But I'm wondering whether such sites are actually standard control. They are what we would consider to be standard controls. Even you've been there since 2011 or 2012, and I'm wondering whether they are in any way the same level as what the other regular health facilities in Uganda are, and whether what you call control is not already way above what the standard of care is as we know it. Yeah, those are my comments. That actually what you find, you might find a small difference, and yet if you compare that to the actual facility where there hasn't been any interventions like that such has provided over the past 7 years, that you might get a clearly different picture. Actually, Richard.
Yeah, thank you very much for this. And I'm trying to look at your aim one to determine the equivalence and identify predictors of viral suppression. Yeah, clearly, the equivalence of viral suppression. How many among all these that have suppressed? Then, what predicts viral suppression? Maybe I'm trying to look at the other way around. You want people to suppress, but the people don't want it. It's those who don't suppress, isn't it? So, am I looking at the predictors of those who have suppressed to guide those who have not suppressed?
It should be like viral suppression.
I'm just trying to, because they have suppressed. Why do we? Because maybe it may not apply to the other, but looking at the other ones who are not suppressed, and you see what it is.
You carry the whole point.
Yeah, that's what I was trying to do.
Okay, thank you.
Thank you very much, Jane, for that quite interesting study. And I really liked it because at least I've seen something similar, so I'm having that somewhere. It's an addition, or if you thought about it, if you're going to train, that's one, and you're going to do enhancement. That's called basically training, and I think it's going to be one of your major interventions in that study. One of the bottlenecks which you encounter, you ask you how sure that the training really was that benefited the people. Dr. Fred has said you need that actually the tools you are dealing with are already contaminated, which actually are also not here. Probably it would have been better if you went to completely the 9 clinics, so that if you train clinics, you can say these were baseline clinics, and this was the effect. And then secondly, really classify the training method and what you're going to tell the patients, because, or the training, because you'd be asked if you are trained, what did you tell the information that you sure the information you told them was put into practice. So think about that.
Okay. Thank you.
Well, last, I don't know whether to say this, but you know, am I conflicted because I'm one of the supervisors? I may be conflicted, but you see, when you present and you say, you tell us, for example, when she presents, I can tell what, for example, what is the design? The design is a cluster randomized trial before and after. You know. What is the hypothesis? The hypothesis is that peer mother counseling and viral counseling will lead to enhanced viral suppression. What is the intervention? Interventions. Peer mother counseling, viral counseling. What is the outcome? Viral suppression. I can remember like everything, but sometimes people present, you say, okay, what is the hypothesis? What is the outcome? What is, if you can learn to present very simply. Now, I'm not saying that people present it badly, but it is like sometimes, you try to imagine what is the outcome, what is the predictor in this study. Now, I'm just saying that they were so clear in this presentation. Just adjust for my being.
Okay, thank you so much.
Actually, and
The intervention.
the intervention is not routine, it's not part of routine that's supposed to be by Ministry of Health. It's supposed to.
I'm not the one answering.
I'm trying to see.
I think I can.
To me, from the layman perspective, it looks to be everyone should get it. But when it becomes an intervention and people are randomized to something, then it looks like there is something else which the ministry offers versus this. But I'm expecting everyone is cancelled, everyone is given this. And maybe how different is it from what the ministry, because you understand better that problem.
Okay, thank you. I'll respond to the three questions and comments. Number one, I mentioned that aim 1 would specifically be from the search. But the other aims, like we have clearly mentioned, what the search study has been implementing, or what it has been doing, is more of the intervention. So for the aims 2, 3, and 4, we are getting out of the search study. I think that is one. And so that answers the question of generalizability. But for aim 1, we are already using the data from the search study. And that will guide the next steps. About whether it is the mothers or health workers for aim 3. Aim 3, we are looking at retention in care, and this is the mothers who have been enrolled into this study. The second is coming from Dr. Katamba, and the question is, why are we interested in viral suppression and not non-suppression? And that is a good question. However, it doesn't mean that we will close the eyes to the non-suppressors. But the interest here is we want to learn from the best practices usually. And so if we have people who have suppressed, you want to know why they have suppressed, so that you can use that to make the intervention richer, so that you can target the non-suppressors. And so that is the mind behind the interest in the suppressed, because we want to know why they are suppressed, and then we can use that information to help the non-suppressors.
Yeah, it's a good assumption that the non-suppressors, those things will relate to them.
Exactly, it is a good assumption, and
but I think you find it's a very different population, and when you do that, it does not work out.
Yeah.
Because what you want to target is the people who have not suppressed food. Suppress.
Yes.
But you are saying, I'm going to look at those who suppressed and know why it's not suppressed. I may be very different. I wonder whether you are answering the question.
I think you're right. You're right, and I'm right. And so I think we just need to agree on the next steps. And like I said, we have the data both for the suppressors and non-suppressors. However, our aim in the suppressors is to build on our intervention. But we can still go ahead and look at the two groups and see whether there is something that, what are the factors that, what is causing the non-suppression that can also be pulled to target in terms of the intervention.
The husband may be supportive.
Exactly.
And you find that the other husband is not supporting. Knowing that the other one is supporting does not make you change the other husband to be. So, you see what
when you are doing the logistic regression, you can say, I mean, if you use viral suppression, you might say these were more likely to suppress, or these were less likely.
And we don't want people to actually go into non-suppression. So if you can capitalize on what factors make them suppress, then we can capitalize instead of waiting them the other side and then. So I would think for me, I still support looking at this, enhancing this, strengthening, so that I have as few as possible crossing over.
But you are dealing with two different populations. The ones who are already crossed, you can't just use this model to have both. So,
maybe that is why, if you look at the aim form, and that's why we are now changing direction when we have implemented the intervention, and then our target is looking at those who have not suppressed and why they have not suppressed. That is now at the end of the intervention. But at the beginning, in terms of the baseline, we're interested in those who have suppressed and see whether we can, employ the same gears to have the others suppressed. That is about that. And then there was a question from Richard quickly. Yeah, I think I partially answered that when I said that the 3 aims will be out of the search community. And in terms of the bottlenecks, how do you answer the question of how did you train and what? We shall have standardized tools that we shall use so that you can clearly measure the outcomes. But also in terms of the messaging, we intend to have a standard message that will be given to all participants so that it is easy to measure how that is done at the end of the study. Thank you.
yeah, thank you, Jane. I think
about the difference between, okay, so I think briefly about the difference is that the counseling is happening. We didn't say that the counseling is not happening. But what happens is that, you have so many things that you have to touch when you interface with this patient. You have talked about nutrition, A, B, C, D, E. We're not saying that that is wrong. It will continue in the other sets, in the controls. And in the interventions, it will also not be off, but the focus is going to be the targeted viral counseling that each mother should not go without receiving, even when they have received anything else that they're supposed to receive. So it will be that this one message that must always be given to this mother. Because I'm pregnant and the focus is reducing the risk of MTCT, I must always receive this particular message in addition to the other things, which message will not be available in the control clinics. But also we know that the peer mothers are going to be in both clinics. But like I said, they have a range of activities that they do, but what we're trying to do in this intervention is to focus them and say that if you're dealing with a pregnant woman who is HIV positive, our primary aim is to make sure that she gets an HIV-free child. And so you don't want to talk about anything else and leave out the viral counseling. So that is like briefly what I can say about it.
Yeah, thank you, Jane. And I think one of the things we are talking about the virologic study that we are going to do in the same areas, and one of the things that came up, these are very key issues that the Ministry of Health is focusing on. Even tomorrow, the other day, they are calling us for meetings to discuss these issues. These are target populations that everyone is looking at. So I'm sure even the people at EGPAF are thinking very deeply about the same ideas that we're thinking. So even in the control facilities, there is a lot of things that are going to change. Meaning that maybe if your intervention works or does not work, may not necessarily mean that it's a true finding that it's your intervention that has not worked, especially when it doesn't work. Because there is a lot of background action that is going to be happening, even in the control facilities. So I guess what I'm suggesting is that you need to be in touch with the implementers in the area and what they are doing so that you clearly document it on a very, very regular basis, so that you can be able to tell the things that changed as we are conducting your study. Next.